Hi everyone, this is Aurelie Najm from Glasgow, and today we are on for the QD clinic. I'm going to talk to you about a patient that has been attending my clinic for about 4 years now, and the situation we have been on over time. So this lady is 65 years old. And she started attending the rheumatology clinics 4 years ago for originally issues with coughing and breathlessness. And that led onto diagnosis of diffuse systemic sclerosis. So at the time, the lungs were crackling. There was some skin involvement, and actually, upon asking her how long she's been struggling with her cough, we also realized she had a rhinos for about 10 years. And then she had obvious telangiectasia, and then the antibody profile was RNA polymerase 3 antibodies and anti-Ro52. And so that at the time told us that, as you know, she was more likely to have a severe skin progression, rapid lung progression, as well as a higher risk of renal involvement. And so, following that, she was rapidly diagnosed upon HRCT with a non-specific interstitial pneumonia, as well as that was moderate on the CT at the time, and she was started on mycophenolate, as well as a small dose of glucocorticoids, because obviously, due to the risk of renal crisis, we couldn't really get her on a higher dose. And so we kept seeing her over the years, and she was doing pretty well until 2 years ago, when things started to. She presented again with worsening of her breathlessness, and on the PFT we realized that the FCV had dropped for about 10%, so from 85 to 75, and the HRCT confirmed that there was a mild worsening of the lung disease, and therefore we got her started on antifibrotic. And by the way, this combination of mycophenolate and indatinib is with low dose of glucocorticoids is currently what's recommended for CTD ILD in the ESR EULAR recommendation for CTD ILDs. Obviously, at the time they weren't published, but if you're interested to read more about these recommendations, there's a really nice article that's on the RheumNow website for the ILD month. So I invite you to go and have a look at that. But that's how we treated her a couple of years ago, and then things kind of stabilized for a while. Now, 6 months ago, she had a lung infection. Following what, really, she didn't recover really nicely. She started to really complain of breathlessness to a point that we thought, okay, we're going to have to do PFTs and HRCT again. However, something in the PFT really rang a bell for us at the time, which was that the DLCO had dropped massively, so from 50 to 19%, with an FCV that was still roughly around 75%. And so that for us was already a sign that something was not right, but not necessarily in the sense of her lung disease progressing, but maybe that was a sign for pulmonary hypertension. And so she got a transthoracic echocardiography. However, this is not always really helpful in people with systemic sclerosis ILD because of the lung fibrosis and the skin stiffness. The results cannot be always in favor of pulmonary hypertension. And so the recommendation in these patients with an unexplained worsening of breathlessness or high risk of pulmonary hypertension, or when they're candidate for transplantation, the recommendation is to go to the right heart catheterization, which this patient had, although the echocardiography was already showing signs of moderate right ventricular dysfunction, which were obviously evocative of pulmonary hypertension. And so the pulmonary hypertension was confirmed in these patients, and then she was started quite rapidly with a combination therapy. So in her case, it's always a bit more difficult. So pulmonary hypertension, when it's idiopathic or in systemic sclerosis without lung disease, usually the recommendation is to follow the guidelines for PAH group number 1, because that's without ILD. However, in her case, due to moderate interstitial lung disease, we know from clinical trials in this group, so the group 3 of patients developing pulmonary hypertension following prolonged hypoxia, the treatments for pulmonary hypertension don't work as well. And there's been quite a lot of negative trials, in particular in severe ILD. In her case, we're lucky enough that the lung disease was not that severe. And so she was started on phosphodiesterase 5 inhibitors and prostacyclin agonist as a combination. And that helped a little bit for her symptoms, because at that time the breathlessness was so severe that she couldn't do any form of activity. Even speaking was as well as she needed oxygen. So and obviously she's now on the list for transplantation as well. But I think one of the reasons I really wanted to talk to you about this patient is because we tend often in people with non-interstitial lung disease to in case of worsening of breathlessness, to think about infection or to think about worsening of the lung disease. And I think it's really important in these people to remember as a learning point today that pulmonary hypertension is one to look for, in particular when the breathlessness can't be explained by the lung disease, when the DLCO drops massively compared to the rest of the PFT parameters, and or when there is necessarily no cough or no other signs associated with the breathlessness. And so for this patient, we're able to quickly diagnose her and get her on a treatment. But that's definitely something to remember. On the other hand, I wrote an article recently about treatment of pulmonary hypertension in the context of CTD. So I invited you also to look at that on RheumNow website. So that's me for today. You're welcome to go on the RheumNow website for more QD clinic and enjoy the ILD content over the whole month of September for the campaign. See you later.